Welcome everyone to our next session, Blood Cultures, Myth versus Fact. It's my pleasure to introduce this esteemed panel for this presentation. Now there's three of them and their bios are on the web, so please go there and read them all. Just know that they're experts in the field. So it's my pleasure to bring in Tammy Johnson, Cheryl Kelly, and Dr. Donna Matoka. Guys, take it away.
Thank you so much, Judy. It's such a privilege to be here today, and we thank each one of you for participating in this session. Most of all, we really wanted to just say thank you. Thank you for persisting within healthcare and vascular access and really bringing all that you bring to our patients. We know you make a tremendous difference, so sincere thanks on behalf of us. Today, when we look at this, I just need to explain that I do have an employed position with Magnolia Medical Technologies. I will not be speaking to anything that is off-label or investigative use. And really, when we look today, we're going to look at how we diagnose sepsis and the problem with blood culture contamination and really what that impact is on our patients and our hospitals. And we'll look at some evidence-based practices, which Cheryl is going to define for you in great detail, and then look at the evidence between ISDD, initial specimen diversion devices. We're going to discuss the proposed new national benchmark of 1% coming from a 3%. And really our learning objectives for you today is be able to describe that impact of false positive blood cultures and what it does mean for our patients and our hospitals. We're going to take a little bit of a dive into CLABSIs, and we want you to be able to illustrate that maybe to your vascular access team, but also your CLABSI team as well. And we also want to review the role of the clinician in blood culture collection and how very important it is for this diagnostic test. So let's look at the problem of the diagnosis in sepsis. Sepsis, as you know, is the #1 cause of death and readmissions in United States hospitals, and blood cultures are remaining the one gold standard for diagnosing this disease. And so the problem with that, though, is that, as you know, these tests frequently come back incorrect or wrong. When we look across the United States, only about 8% of everything that we send to the laboratory, and as far as the blood culture, grows out anything at all. But when we look and see that we are currently accepting a 3% false positive as a standard, we only have 8% again that grow out anything. So if you put 3 over 8, it really equals a 40%, 38% to be exact, okay false positive rate. And I would submit to you that that is really not an okay rate for our patients on this very important test. So let's look at some of the problems with that. It brings a clinical decision dilemma. Most frequently, we pick up coag-negative staph on the skin when we're doing the blood culture, and that is most commonly our contaminating organism. And the problem with that is that if we could just look at that and say, well, it's coag-negative staph, it's garbage, it's trash, we picked it up on the skin, throw it out. But that's not the case. 15% of the time in you and I, a healthy population that spikes a fever and walks into the ED, we understand that 15% of the time, the causative organism in this group of patients is coag-negative staph. And if they have a central line, a CVC at all, it's 38% of the time that coag-negative staph is causing a true bacteremia. So getting this false positive result, you can see the diagnostic conundrum that puts us in. What do we do with this patient? Do we continue antibiotics on them? Do we admit them? And 65% of the time, that is what we do. And so this patient then has a lot of downstream sequela from the unnecessary antibiotics. One of those things being antibiotic-resistant infections. One of those being the risk of gaining C. diff. And as you know, we lose anywhere from 15 to 30,000 patients every year with C. diff in the United States, and that's just within the first 30 days of onset. Our go-to antibiotics that we give are typically Vanco and Zosyn, and we can have up to a 36% chance of causing acute kidney injury with that combination of antibiotics. And then we talked about an extended length of stay. It's typically 2 days. And what that does is it allows exposure of our patients to HAIs and HACs because we have some very virulent hospital organisms that we are exposing them to. And then we're going to take a little bit of a look at false positive CLABSIs. So in a typical hospital, what does this mean? If we take 1,000 blood cultures a month and we say that there's a 3% acceptable contamination rate, That affects 30 patients every month, 360 patients a year. And if we look at 9 studies and 2 recent studies, all of them tell us that the cost is anywhere from around $3,000 to $9,000, and typically it's around $4,000. Now, that is an avoidable cost of $1.4 million. The CDC tells us that there are only 4 ways to stop antibiotic resistance. And the first is to prevent an infection from happening in the first place. So we don't want to be causing CDI in our patients. And then we want to prevent its spread. So definitely we don't want patients hanging out in the hospital unless they absolutely have to be there. With that extended length of stay, that keeps them in the hospital and gets them exposed. And need to implement as necessary and appropriate. COVID, we saw a tremendous loss of gains that we'd had with antimicrobial stewardship. 72% of our COVID patients actually received antibiotic therapy, but only 8% of them had a documented co-bacterial infection. And so when we have diagnostic stewardship correct, when we get the test right, when we're able to grow out the organisms that we're really looking for in the bloodstream and not what was on the skin, we have everything aligning with our sepsis protocol and with our antibiotic stewardship. That's a great place to be for our patients. Has true quality out. So let's look at blood culture contamination and CDI. The CDC actually did a study and they said if we would lower the use of our broad spectrum antibiotics by 30%, we could actually lower our CDI rates by 26%. So almost a 1-to-1 correlation there. And then, of course, our go-to antibiotics that we already looked at, Vanc and Zosyn, increasing the risk of AKI, have both also been implicated in the causation of CDI. And so we know that that diagnostic stewardship, again, prevents much of that. And so let's look at blood culture contamination and false positive CLABSIs. As you know, we have done so much to prevent CLABSIs, and thank you for being on those vascular access teams and really being the ones that are really inserting these lines very well and maintaining them very well. But we have done so much, right? We started with education and insertion bundles, and we used hand hygiene and maximal barrier precautions. We used CHG. We chose sites optimally. We had set up observers and had checklists. And then we saw maintenance infections happening. So we set up maintenance bundles, right? With CHG bathing and dressing and the right connector and tubing protocols. We used port protectors. We assessed catheter need and got it out as soon as possible. And we had vascular access teams. So thank you for being those teams and for really being the guardians of these lines. And we had daily and rounding auditing. Really in 2011, this all started with NHSN's mandatory enrollment and CLABSI reporting. In 2015, the hack penalties started. And all of this caused great things, right? We improved on our CLABSI rates, 44% from 2008 to 2016, and again, another 7% from 2018 to 2019. And yet, it's always the requirement to get better, right? The 2020 target was a 50% improvement on our 2015 baseline. And what happened? COVID. And then what we saw really was a 28% in CLABSIs across the nation when we compared Q1 of 2019 to Q1 of 2020. And there was just recently a phenomenal article in Itchy Infection Control Hospital Epidemiology by Lindsay Weiner-Lestinger that showed a 53% nationally when we compared Q3 2019 to Q3 2020 in our CLABSI rates. So some very significant losses there for our patients. So what is this false positive CLABSI we're referring to? A false positive CLABSI is defined in the literature as really meeting the NHSN surveillance definition of a CLABSI with little to no clinical manifestation of a bacteremia or fungemia in our patients. And so this usually occurs when we pick up a non-common commensal organisms, not those coag-negative staph usually, but we're picking up something like a VRE or a candida on the skin during a peripheral stick. So we're not talking about those CBC draws, but a peripheral stick. And then we know that the clinical definition always trumps, the surveillance definition always trumps the clinical definition. And so we have to report this as a true CLABSI. And so there are 3 different articles on this in AGIC, and we're happy to share those with you. If you would like them, you can let us know. So when we look to initial specimen diversion devices, it really is the end game for diagnostic stewardship to mitigate those false positive CLABSIs. And how does that happen? Well, even if we had a rate of 0 blood culture contaminations, that does not equal 0 false positive CLABSIs without the use of initial specimen diversion. And the reason for that is it doesn't really matter what's dwelling on our skin, right? Whether it's a common commensal organism or a non-common commensal organism, we don't want to pick that up and get it in the blood culture bottle. And so what ISDD does is diverts whatever organism is on the skin. It goes into a sequestration chamber. That chamber is closed off, a new sterile pathway is opened up. And so what goes into the blood culture bottle is truly what's in the bloodstream. And then that mitigates those misdiagnoses that we have with all the clinical and the economic sequelae for our hospitals. So when we look to the economic sequelae for hospitals of getting a false positive CLABSI, it happens really in 4 different categories. The first thing that happens is we get non-payment for the rest of the patient stay from the day of diagnosis of the hack to the day of discharge for that patient. The second penalty area is up to a 2% loss of annual reimbursement for every CMS patient seen for the entire year when we have that hack. And then readmissions, we can have up to a 3% penalty of annual reimbursement if we exceed our readmissions rates. And value-based purchasing was really our chance to really outperform everybody else in quality metrics and be able to get not only the money set aside into that fund, but our competing hospitals' monies back. So the top quartile of hospitals has a chance to really gain money when we get quality right for our patients. And it really should be that way. So when we look at this, how much is involved in this? When we do a hack penalty calculation, about 32% of all of hospitals' income in a short acuity hospital, typically about $1 billion of income, even with a 1% penalty on these hack penalties, would equal $3.2 million. So you can see we're looking at very significant potential loss with these hack occurrences. University of Nebraska Medical Center did a great study, and they said, let's see what happened in our patients with a retrospective analysis of when we got the blood culture right and when we got it wrong. And what they saw is that when we got the blood culture wrong, they had a 23% increase in hacks in those patients and an 11% increase in readmissions. And that seemed like crazy high numbers. But when you consider what we're doing to the patient's gut, we are disrupting the microbiota balance of that patient's gut, which determines that patient's ability to have an immune defense in full capacity. And so when you see what we're starting to do to those patients, plus they're in the hospital where we actually expose them to more robust organisms, you can see how these things occur. So the challenge and the solution, it really isn't anybody's fault. When we look to training and education on best practices, it is vitally important that we do everything the way we're supposed to do it, that we have eyes on us, and that we do evidence-based practices every single time in every single step. But that alone does not sustainably solve the problem. As important as education is, we know that when we're putting parts and pieces together to get a blood culture, we have the risk of touch contamination. And when we clean skin, even if we're going to do an OR scrub, like a pre-op scrub, we know that 20% of the normal skin flora stays viable in the deep keratin layer of the skin, even when we've done our best scrub. And so when we put a hollow bore needle all the way through all of the layers of the skin to get into the vessel and get our blood culture, it can contain a skin plug, which can contain those organisms. And we then transfer them right into the blood culture bottle where we grow something out. But again, active diversion of the initial 1.5 to 2 mils of blood using a closed system has been clinically proven to reduce those blood culture contaminations and allow our patients to have great outcomes. There's a great article in BMJ that just said training and education tends to produce no improvement in interventions. And yet when we force functions, when we engineer a solution, and we engineer out human variability, that's when we really see sustained differences for our patients and our quality outcomes. Cheryl's going to go over the evidence-based solutions with you in a step-by-step, and that's exciting because we can do so much with that. And then we'll see that when we take evidence-based practices and we combine it with an evidence-based technologies, we understand that we can set a new standard for our patients, right? We can have reductions in false positives up to 100%, rates as low as 0 for 10 months sustained. a positive predictive value when a device like this is used of 97%. That means when we get a coag negative staph, we can be pretty darn sure that we're treating that patient 100% appropriately. And so again, that can shorten that patient's length of stay by an average of 2 days. And we can then reduce our hacks by up to 23%, which is phenomenal. And then obviously just eliminate that misspend of almost $1.9 million because we're not keeping the patient in the hospital unnecessarily and treating them unnecessarily. When we look at the ENA's guidelines, when they did a evidence-based review, they said that diverting the initial 1 to 2 ml of blood into a sterile container had been proven to reduce rates in the emergency room setting. So looking at ISCD, the evidence from diverting and sequestering 1 ml of blood, 6 peer-reviewed published articles on this in major medical journals, and we would encourage you to seek this out, but we wanted to dive into a couple of studies. One is the University of Nebraska Medical Center. So Dr. Mark Rupp set up this study because he had a rate under the current 3%, that's a quote, allowable and acceptable, of 2.6%. And yet he knew that there was so much patient harm coming from that. And so he set up a study with his phlebotomy group, and in one arm of the same patient, they would do evidence-based technique. And look what happened to their rate. We see that the rate went down with just best practices, right? 1.8%. And we know that happens because we all drive differently with a cot behind us. And yet, in the contralateral arm of the same patient with the same phlebotomist using this ISDD technology, they were able to go down to 0.2%. And that was sustained over 1,800 cultures, a 97% positive predictive value. And the great thing was there was no change in true bacteremia. So we were really capturing the organisms that we wanted to catch. So when they looked at this and they just studied it over 1,800 cultures over 12 months, and then they took the product away and they shot back up to 2.8%, even higher than in their starting rate. So significant evidence there for you on that study. Lee Health multi-center hospital study, they had phenomenal success going from 3.5% aggregate average in their EDs with an 83% reduction with ISDD all the way down to 0.6%. And the wonderful thing about this study is that 86% of those ISDD blood culture draws were drawn with a Fresh Start IV. So there was no difference in the peripheral sticks and the rates they got through ISDD or if they connected to a Fresh Start IV. So excellent news there, especially for the emergency room environments. A study at BAMC looked at their starting rate of 7.7%, and they were able to take this down with ISDD all the way to 0.6%. So phenomenal results. The second arm of this study is really where it was very impactful for patients because what they did is looked at days of therapy with vancomycin, and they were able to have a 20% reduction when they put in PCR. So that's rapid organism identification, and they got a 20% reduction in their use of vancomycin hospital-wide. But when they put in ISDD, they had an incremental 37% reduction. And so that is tremendous news for our resistance. We have such VRSA going on, and it's so phenomenal to know that we can really impact vancomycin dosing by getting this right with an accurate blood culture. So let's look at a study at Stanford Healthcare. They put an ISDD device in. It had a starting rate of 2.3% and then a 100% mitigation and down to 0.0% blood culture contamination with ISDD. And the purpose of the second arm of this study was really looking at how could this prevent those false positive CLABSIs, those one bottle pickups of VRE or Candida on a peripheral stick on the patient. And they had only one false positive CLABSI with the use of ISDD compared to 12 false positive CLABSIs within that same time period when ISDD was not used. So phenomenal results there for those patients who didn't need to receive a 10-day antifungal therapy because of collecting something on the patient's skin. We've talked a little bit about cost associated with blood cultures. There were 2 studies back to back, $4,700 and $4,800, and they were just published a month apart, but you can really see a very consistent cost here for our hospitals. In total, 19 studies now on ISDD, 16 where you see phenomenal results for our patients. But the least percent reduction that you see on this list is a 75% reduction, all the way up to 100% reduction. So, really phenomenal evidence for our patients. And there is a new benchmark coming. I don't know if you've heard anything about it from CLSI, but we're thrilled to tell you that since there is so much evidence about when we get the practice right, and we use an evidence-based technology of diverting a mil of blood into an ISDD, sequestering that sample away, and then opening a new chamber and really being able to get into the blood culture bottle what's represented from the patient's bloodstream rather than what was on their skin. They said there should be a new standard for our patients. And so this started with an article that came out from really who's who in pathology, infectious disease, microbiology, and they said we really need to do better for our patients. And so this article was published, and then CLSI has now proposed a new national benchmark as well in their proposed guidelines. And so this is, again, very exciting news for our patients. And when we look to INS as well, you can see their standards and recommendation of diverting a mil. And in Congress just voted for the Department of Veteran Affairs in a MilCon VA Act that we should also have a 1% standard for our VA hospitals. And our veterans do deserve the best, so we are very, very excited about this. So when we look at national patient safety goals, using an ISDD device will actually help you meet National Patient Safety Goal 70301, which says that we should do what we can to reduce resistant organisms from being developed in our hospitals. And by getting accuracy with the diagnostics in the front end, it then allows, again, for us to have great antimicrobial stewardship, which leads to quality patient outcomes. So we are so excited to have you as part of this think tank and ask you as healthcare providers, won't you please invoke and join industry and policymakers and create a new standard of care for our patients who deserve our very best. Thank you again for listening to me in this. We hope it was helpful for you, and I'm going to pass this on to Cheryl, who's going to give you some very practical tips on how we should draw a blood culture.
Thank you, Tammy. I appreciate that. I do have some financial disclosures. I am an employee of Magnolia Medical, and I'm a stockholder for several companies as well. Next slide. So, what we're going to talk about today is perfecting the blood culture by looking at practice and technology. I know I'm speaking to a group of experts when I speak to the vascular access folks in the world, but I hope to bring you some new information from that you may not be aware of as far as national guidelines, some clinical best practices, different technologies, and then I have a whole section on focusing on the fill volume of the blood culture bottle. So we need to get it right. If we don't get it right, what are some of the things that can happen? Tammy had mentioned a false positive blood culture, and this occurs whenever organisms that end up in the blood culture bottle are not necessarily the organisms that are from the patient's bloodstream. So it's a problem for the hospital, it's a problem for the patient. When we look at a contaminated blood culture, that is skin flora. Generally, they're gram-positive organisms that, as I said, end up in the blood culture bottle. And the physician then has to determine, am I going to treat this patient or am I not going to treat this patient? And generally what happens is the physician does continue treating the patient. However, he will reorder a blood culture. And generally, it takes about 48 hours for that blood culture to come back with any type of results. When we look at a false negative blood culture, a false negative blood culture occurs whenever we suspect that there are microorganisms in the specimen, but however, Nothing grows on the gram stain or grows in the bottle. And this is the most problematic for the patient because our patient may be bacteremic, and for whatever reason, we just couldn't get the blood culture to return a positive growth. Some of the reasons that this can happen is if we don't collect enough blood in the bottle. That's why fill volume is so important. It can also happen whenever there are antibiotics administered to the patient prior to the blood culture being collected. So that creates a huge problem. So we do need to be aware of the fill volume in our bottles. So whenever you look at drawing a blood culture, there's a handout that goes along with this course that does give you some very in-depth tips and tricks, methods for drawing an appropriate blood culture. But basically, what we'll need to do is we do need to collect 2 sets of cultures, and I'm going to talk about that just a little later. The skin needs to be disinfected. Unfortunately, we can't sterilize the skin. So the skin is disinfected. The bottles are prepared, which means that we're looking at the amount of blood that needs to go in the bottle, as well as cleaning the tops of the bottles so that those are sterilized and there's no bacteria introduced into the bottle itself. And then the last thing is, of course, collecting the blood culture itself. We want to use aseptic, non-touch technique if at all possible, and we'll get 8 to 10 cc's of blood in the bottle. So let's take a look at these guidelines. I know you're familiar with this center, Infusion of Nurses Standards of Practice. I listened to Lynn Hattaway today, and she talked so much about the standards of practice. I know you're familiar with that, but just to let you know, the Emergency Nurses Society also has some standards and guidelines related on how to collect blood cultures. The reason that ENA is so concerned with this is because about 50% of your blood cultures that are collected are drawn in the emergency room. I don't know if that surprises you or not. So if you're doing 1,000 a month, we could pretty much guarantee at least 500 of those are drawn in the emergency room. So if the emergency room gets it wrong, then it's wrong for the rest of the patient's hospitalization. And the last group you may not be familiar with is the Clinical and Laboratory Standards Institute. It's a global, not-for-profit organization, has 24,000 members in it, and it's recognized in laboratories as the guru for looking at standards and practices relating to multiple areas of the lab, not just blood cultures. So let's take a look at the national guidelines, and we'll be looking at education and personnel. This is a B recommendation, and this is from the Emergency Nurses Association. Provide education and training for those who collect blood cultures. And we know that's probably the first area that has been looked at in your hospitals to reduce this problem. It's easy to implement, but the results are unsustainable. Another area under education is to monitor the blood culture contamination rates and provide data back to the individuals. Are you aware of your blood culture contamination rate in your hospital? If you're not, then it's something that as vascular access nurses expanding their scope of practice, this is an area that you probably will want to focus on. When we look at personnel, it's very obvious. Look at what we're doing with vascular access. When the experts start the IVs and obtain the bloods and place the lines, there are positive results. The patients are more satisfied. There are improved outcomes. Unfortunately, whenever we have a team that draws strictly blood cultures or phlebotomy teams, they're very costly. And the other problem is you still don't remove all of the sources of contamination, which are the skin plug or the surface organisms that the ChloraPrep misses. Let's take a look at skin disinfection. I took these all of these statements from the various INS, ENA, and CLSI. So the first one is to use a chlorhexidine solution to draw blood cultures in patients greater than 2 months of age. And of course, it's an A level 1 recommendation. If there's a patient under 2 months of age, you'll want to use alcohol to clean the patient's skin. The other thing is the instructions for use for most of these products are to scrub for 30 seconds and then allow to air dry. If you're using a large amount of chlorhexidine in a small space, it's going to take longer than 30 seconds to dry. So just be aware that the solution must pass through the skin, through the subcutaneous tissue to the wall of the organism, enter the wall of the organism, and then cause that organism to rupture. And that process takes the amount of time for the solution to dry. Apply alcohol solutions with 30 seconds of vigorous scrubbing, I think is something that everybody's doing. And I know this will maybe entice some questions. I took this from the CLSI standards. If povidone iodine is used, it should be applied in concentric circles. I thought we got rid of that years ago, but this is from the standards and the guidelines. It does need 1 to 2 minutes and up to 6 minutes to dry for proper skin disinfection. Next slide. Oh, so let's look at bottle top disinfection in a standardized kit. These come from the guidelines, and what we're looking at is cleaning the septum of the bottle with 70% isopropyl alcohol. Again, it does need to air dry. The cap that's on top of these bottles is simply a dust cover, and it isn't sterile underneath there. So scrub the top of the bottle for 15 seconds with a flat swab. That was recommended in some of the guidelines, and allow it to air dry at least 5 seconds. You'll notice in the handout that we have for you that it's a recommendation to also place a new alcohol pad on top of the bottle. And what this will do is protect it from anything in the environment. A standardized kit is a level B recommendation to either use a sterile culture bundle or an assembly of kits. And so we're seeing that with central lines and other procedures. The double needle technique is a level B recommendation, and this simply means that if you perforate the skin with one needle, you do not use that needle or whatever it is that you're using to get the blood, you don't use that to transfer the blood into the bottle. You should inoculate the blood culture bottle with a different needle. When we look at standard procedures, there should be a standard procedure in drawing blood cultures. It's recommended in the literature to draw from a venipuncture site, not an intravenous catheter. When I review diversion technology, I think you'll find that may be changing some of the standard techniques. We're going to focus on initial specimen diversion. And again, these are the diversion volumes that are recommended from various organizations. And that recommended diversion volume is greater than 1%. Anywhere from 1 to 2 mils is the diversion volume. So let's talk about manual diversion. Manual diversion is the process in which the first couple mils of blood are discarded prior to the sample collection. The strengths with this are its low cost. It will give a modest reduction in blood culture contamination rates. It's generally performed by performing the venipuncture and then putting a tube. Generally, it's a red top or a gold top into the transfer device, discarding that, and then putting the blood culture bottle on. The problem that this creates is it's difficult to disinfect the top waste tube if it isn't sterile. And per the literature, it's difficult to sustain these results. This is a look at, by the way, manual technology will reduce your contamination rates around 50%. When the two types of manual diversion are a bundled kit in which the nurses assembled by just taking pieces of product into the patient's room. And then there is a prepackaged kit that is sterile and contains all of the materials that are necessary. When we look at mechanical diversion, that's a closed system that diverts and sequesters the initial amount of blood prior to the collection of the specimen. The strengths with this, there are multiple configurations for all ages of patients. The user creates a vacuum by the amount of pressure that they use with the device to assist with the blood return, which is helpful when sticking smaller veins of the hand. It does require a practice change, and it does require training on the use of the device. There are multiple peer-reviewed studies which show that contamination rates can be near zero with this device. This is an example of a diversion device that has a transfer adapter or a syringe for those syringe users. It is compatible with both syringe and transfer adapters, as I mentioned. So I'm going to move on to perfecting blood culture now in my next section. I've got about 10 minutes left, so we will move forward with that. So how important is fill volume? And hope I'm teaching you something new, but adequate fill volume is the single most important factor in the detection of true bacteremia. So when you look at your blood culture bottles, overfilling the bottles, as we discuss, can create a false positive. And how this occurs is the bottles are designed so that there is a disc in the bottom of the bottle that measures the amount of pH change in the bottle. So if we overfill that bottle and we collect numerous white blood cells, they respire, which in turn creates CO2, which in turn creates a pH change in the bottle, and the bottle will alarm as positive, even though it is a false positive. So that's why the fill volume is so important. The other thing to consider, rates of blood culture contamination are higher with low fill volumes. So let's think about that a minute. If I'm not able to get my 8 to 10 cc's of blood in the bottle, I would like to think that's probably because the patient is a hard stick. There's manipulation of the device, manipulation of the needle. There may be a break in practice. So the literature supports that hand in hand, hard sticks are associated with higher contamination rates and with low fill volumes. Also, just to remind you, if our bottles aren't held vertically, we can't measure the fill volume and accurately, because whenever that bottle is placed vertical, the fill volume does change in the bottle so that it's easy to get an overfill. So let's talk about how we can maximize the recovery of organisms. The first one that we're going to talk about is distribution of the blood between the aerobic and the anaerobic bottle. So what are aerobic and anaerobic bottles? An aerobic bottle enhances and allows for the growth of organisms that need oxygen in order to grow. Anaerobic bottles, on the other hand, support organism growth with pathogens that don't require oxygen in order to multiply and to grow. So when we look at that, one of the reasons we want to fill the aerobic bottle first is there may be some air in, for example, the butterfly needle that you're using. Getting air in an anaerobic bottle would be problematic. The other thing to think about is the aerobic bottle itself is going to grow more organisms that cause true bacteremia. The majority of the organisms that are seen in bloodstream infection and bacteremia will grow in the aerobic bottle. So that's the other reason that we certainly want to use an aerobic bottle first. How about holding the blood cultures in the lab? How does that impact the blood culture? It does impact it, and if it sits in the lab or sits in your tube system for any longer than 2 hours, it can affect the outcomes that occur with the blood culture itself. Let's talk about one set of cultures versus two sets versus three sets. Um, Generally, two sets of blood cultures are ordered in adult patients. And why would we need two sets of blood cultures? That would be 4 bottles, an aerobic and an anaerobic from one site, and an aerobic and anaerobic from the other bottle. The reason that we need to draw two sets is twofold. The more blood that we collect, the higher the likelihood that we're going to collect organisms that are going to grow in the bottle to allow us to determine which organism is causing the bacteremia. The other reason that we want to get two sets is that helps us determine if the specimen is contaminated or not. For example, if Staph epi, which is a common organism that causes contamination, would grow in one bottle in the first set, but not in the remaining 3, chances are it's a contamination. However, as Tammy mentioned, much of the time, in patients that have central venous catheters, nephrostomy tubes, tubes that go through the body and through the skin, those organisms can creep down that line and can actually enter the bloodstream. So there are situations when Staph epidermidis does cause a true bacteremia. And as Tammy mentioned, that occurs about 35% of the time in patients with central venous catheters. How about this? Using pediatric bottles on adult patients. Hey, it's a hard stick. And I know I'm not going to get 8 to 10 cc's of blood in 2 bottles. So I'm just going to use a PEDS bottle. That's not really good best practice, and it is not recommended from any of the manufacturers to use a pediatric bottle on an adult patient. One of the reasons is because there are different components and different volumes and breakdowns of ratios with those components, and for a pediatric patient as compared to an adult. Some of those components in that pediatric blood culture bottle actually are used to enhance the common organisms that occur with pediatric patients. So it's not recommended. It would be better practice for you just to use your aerobic bottle and get as much blood in it as you can. That would be the preferred recommendation for a hard stick patient. So I've got a couple images for you. With the BD bottles that are on the market, these are the long-necked bottles. The clinician needs to mark the fill volume. So put a line with a Sharpie at the level of the broth, and then come up 10 cc's and put another line. Each of the little lines on the bottle are 5 cc marks or 5 mil marks. So make sure that you look at it correctly and put the fill at 10 cc's. The picture in the middle is of a Biomira U bottle. I call it the short fat bottle. And that's what many people recognize it as. You'll see that there's a white line noted on the black line that goes up through the bottle. That's the 10 mil mark. So that identifies for you how much blood you need to collect. And you see all of these bottles are vertical. Take a look at the last picture. This is a dramatic overfill of 5, 10, 15, about 15 to 20 mils of blood. So I strongly suspect this is going to create a false positive blood culture. And when the gram stain is done, nothing is going to grow out. Let's talk about PEDS blood culture specifics. Children have higher rates of bacteria per cc of blood in our body than adults do. So that's one of the reasons that we can get by with less blood collection in children and only the aerobic bottle. I know you're not drawing anaerobic bottles on children. However, if you have a specific bacteria that has a low level of return of organisms, it may only be 1 to 10 organisms per cc of blood. So can you imagine if you collected in an adult patient or a pediatric patient, you don't get your full 3 that you need in peds or 8 to 10 in adults, you simply may not pick the organism up. So then we're going to have a false negative. And then lastly, when you're thinking about your pediatric patients, make sure that you are aware and you are involved about how much blood is being taken from those kids. And generally for outpatients, it's measured by the month, but sometimes in inpatients, it's measured by the day. What about the order of draw? Blood culture should be drawn first. And the reason for that is, think about how you would collect a culture. On your transfer adapter, if you put a CBC or a chemistry tube into that transfer adapter, the top of that tube would contaminate the needle. And therefore, when you put your blood culture bottle on, that needle being contaminated is going to introduce those organisms into the blood culture bottle. I mentioned to you a little earlier about why do we want 2 sites, and the purpose of that is simply to increase the likelihood of recovering organisms and to help rule out contaminated specimens. So let's talk for a second about the aerobic and the anaerobic bottles. The aerobic bottle is the most important bottle. And the reason is some anaerobic organisms can grow in an aerobic bottle. They generally will hover at the bottom of the bottle where there's less air. And aerobic organisms will hang out at the top of the bottle, where nearer to the air source. So it's important that you're aware that the aerobic bottle will collect some anaerobic organisms. When we look at the number of sets to draw, I mentioned to you earlier about how important the sets are, that we do need at least 2 sets. With endocarditis, you will find that anywhere from 3 to 5 sets of blood can be drawn. And if you collect 10 cc's of blood in all of your blood culture bottles, when you're trying to rule out endocarditis, you have a 94% chance of correctly being able to diagnose the organism causing the problem. So that is real important. And I'm ready to finish up now, but I just want to mention to you about central venous catheters. I took this straight from some of the standards, and I suspect this may be a conversation point for you. Send the initial blood aspirate from the CVC without a discard, and that's an INS standard of practice. Newly placed central venous catheters have high rates of contamination. Who would think that? Because we're using such sterile technique when we put the central venous catheter in. However, if you think about how a CVC is placed, the needle is introduced through the skin, and then there is a wire that's run through the needle. There's a dilator that's in and out over the wire, and then the catheter is placed over the wire. So you can see with all of that manipulation of the skin, the contamination rate can be higher with central venous catheters that are just placed. Central venous catheter cultures should be always paired with a peripheral culture. We would then look at time to positivity to determine if the line is the source, or a quantitative count of the number of organisms that are obtained in each specimen. For each multi-lumen catheter, make sure that you draw from each lumen of the CVC. That's not something that I see occurring often, but that is a recommendation from the Infusion Nurses Society. And then lastly, make sure when you're drawing from a central venous catheter, that you change your needleless connector prior to drawing the collection of the blood. Whenever we time blood cultures, it's okay if blood cultures are drawn at the same site at the same time as long as they're from a different site. Blood cultures need to be separated by time or distance. If you're going in the same vein for both sets of cultures, you do need to separate the culture collection by time of 15 to 30 minutes. And then I think this is my last slide, just to let you know there is an antibiotic neutralizing resin that is in many of the blood culture bottles that we have. Because think about a patient that's in the hospital that suddenly spikes a temperature. They've had antibiotics before, 28 to 63% of them. And what the antibiotic resin does is it neutralizes and binds the antibiotic that's collected in the culture. Lastly, does it matter if you draw from a vein or an artery? The blood is the same. So, as far as the quality of the blood, no, it doesn't matter. However, the recommendation is to draw from a vein because it's considered as a safer stick than from an artery. So, we'll review these. Oops, doesn't look like they're coming up. If someone could hit next slide. This is just a summary of all the things that we talked about: standardized kits, as well as skin disinfection, adhering to the national guidelines, making sure the fill volume is appropriate. Consider phlebotomy teams or specialists that can draw cultures, initial specimen diversion devices, and then lastly is education. So I'm going to turn this over to Donna now, and she will wrap things up for us.
Thank you very much, Cheryl. I appreciate all the information that you and Tammy have provided. This leads well into my part of the presentation. So we'll finish up. I know you all have been listening a long time, and we appreciate your attention because this is a very important topic. So my financial disclosures, I do have a few stocks. I will not discuss anything that's off-label or investigational in my presentation. And I work for Medline Industries. My objectives today are to review the role of the vascular access specialist in blood culture collection. I think this is a new topic and area, but I think that I have some compelling reasons why the fit is particularly good. And then just talk about some teaching methods. I'm going to go into a little tiny bit of theory. I know it's the boring thing, but very, very fast. And I think I can demonstrate how utilizing certain theories can kind of give you a method of education as well as following through with quality improvement. So you can go soup to nuts and it can make things very easy and lay it out for you nicely. So why are we talking about the vascular access specialist in the role of blood culture collection? So we know that the procedure should be performed with ANTT in mind, right? And so we saw that in the new standards. It makes a lot of sense, and I think it's really going to improve practice along the way. The specialist, you, are very well versed in sterile procedures because you insert VADs, and therefore you have a very strong foundation with which to either perform these blood culture collections or to train on the procedure. VAD teams are trained in visualization technology, which results in first success, right? The value of utilizing this type of technology within the blood culture space not only drives quality and efficiency, but supports vessel health and preservation. And we talk about hard sticks, right? And we can't get the blood that we need. This is all good. Vascular access teams that are certified understand the concepts of infection prevention and vascular access componentry, right? That primes you to critically think through the impact of drawing through indwelling devices and the steps to minimize that contamination. So you have the knowledge to critically think. Very important. It's true that most of the VAT teams do not perform blood culture collections routinely. You're probably called when it's a hard stick, primarily due to the bandwidth. You guys have been stretched thin before COVID, and I can't imagine the challenges that you're having now. Many teams have been disbanded or cut for financial reasons, which we know is really not a good reason to cut these teams. We save money, and we in so many ways. So we can argue that point, but for the purposes of this discussion, there's a tremendous value and cost savings by reducing contaminations. And Tammy demonstrated the cost savings that exist there. It's significant, clearly pays for some vascular access specialists. So it's supporting the VATS team value, and it embeds you, your role within the hospital by utilization. And then most importantly, let's take a consideration on our patient satisfaction. Just go back for a second. If we have fewer pokes, we have accurate testing, this is all going to impact patient satisfaction positively. So if we look at those false positives, right, it's going to result in further testing, those unnecessary antibiotics that Tammy and Cheryl talked about, the extended length of stay that we all know, and that increased cost to the hospital. But it really is going to negatively impact that patient experience that's so important. So we have literature that demonstrates the value of vascular access teams in many ways, although many hospitals have reassigned some of these tasks performed by you to individual RNs with varying degrees of success. This can really have far-reaching implications that include financial that we talked about, quality that I touched about, safety, and it limits scope and value of the vascular access therapy process, which is very, very important. One area of additional consideration is our blood culture collections. So if vascular access nurses could either initiate or collaborate in safety programs to reduce the risk and costs related to these adverse events, they would be fitting very nicely into one of the INS standards, right? That's part of their role and scope. So several initiatives could benefit from the vascular access nurse expertise, looking at quality improvement, sitting on the team that's looking at antimicrobial stewardship. A lot of information you could share there. Standardizations of products. You know what products work at the bedside. And so sitting on those product utilization teams adds a clinical value that is very, very important. Defining roles. Who should be doing what? Evidence-based practice protocols, very important, and are they feasible at the bedside? And then helping with staff development, adding to your scope here. So Cheryl talked about evidence-based practice, and it's really imperative, right, for ensuring patient safety, and we hear about it all the time. So there are teaching strategies to enhance evidence-based practice knowledge and skills, right? And we see all those recommendations. But current or recent literature shows us that nurses really aren't well prepared to apply the evidence-based practice. So it's one thing to learn it and another thing to apply it. And that's what we have to do in nursing. And that's our transition from novice to expert. So the process of that evidence-based practice is looking at structured queries and searches of quality databases, so we know to go to the ones that are trustworthy and have reliable evidence. We need to make sure we're grabbing the right stuff. In addition, we need to be able to understand how to critically appraise the evidence for reliability, validity, and applicability to the clinical content at hand that we're trying to get. So it can be a little difficult, but there's a process to it. We complete annual competencies. Those have been a little tougher through COVID. And sometimes I feel like we're confusing a teaching and a learning moment with a competency. They are two completely different things. So I said I was going to go back to theory a little bit. And let me tell you, it was probably the most painful course I took in my undergrad. But as I moved through my master's and my doctoral studies, I really grew to value theorists. And so you're probably thinking, why? Is she just crazy? Is she in school too long? Well, it does actually make our lives easier, and we can provide academically strong, constructed nursing education, even in a small setting, right? So we don't have to be a big hospital because it provides us with proven frameworks that work. So we're basically copying it. It's okay, right? So for this presentation, I wanted to think about some theories and some methodologies, right? So I was looking at the constructivist teaching model. Okay, it's really a very good way to go. And I'm getting a little deep, but I have a method to this. So if we look at this type of approach, it's experiential, right? That allows the learner to construct meaning by interpreting the information in the context of their own experience. This speaks to nursing every single day, right? Because we have those personal experiences. There's variability every day in the job that we do, the patients that we have. And we need to internalize the meaning and interpret this information that's coming to us along with our knowledge base. That's how we grow as nursing, right? So it shows active involvement. The environment should be democratic. That's the best. We don't always see that in the nursing world. When we use it for teaching, we want the activities to be interactive and learner-centered. So it's very meaningful learning, and it can be tidbits of learning specific to maybe even one component or deficit within the blood culture collection process, right? It can be comprised, we can do it through group work. It can be inquiry based. Why is something happening the way that it's happening? Why do we have blood culture problems? What do we need to learn, right? So if we are identifying what is going on, we can actually get the answer and then automatically move into a same type of learning format with this model. Direct observation, right? You can, it can be problem based. We have problems all the time. I think we do this intuitively, and it can be cooperative and collaborative. So what could this look like? Down and dirty. We don't have a lot of time, right? So we can Google. Now, Google, I'm not talking about scholarly or scientific, but Google nursing teaching strategies and for examples. You can put in constructivist teaching. You will get more examples than you can get through. And basically, you're going to find out this is what I need to do, and this is how I could do it. Very, very simple, right? I love to use GlowGerm, my favorite thing to do, right? I'm going to put an area where they shouldn't be touching that could potentially they will touch, and then it's going to show the contamination after the procedure is done. So I'm doing observation as well. And then they can see it, they can visualize it, they're experiencing it. You can do videos for education. And, you know, I will give you a little trick from my friend Jill Nolte about this. Your videos don't have to be done in one take. You can do a little snippet. So scene 1, put that onto a PowerPoint slide, do scene 2, put that on another PowerPoint slide. You save it as an MP4 and it plays just like a video. So you can do, a 2-minute video in 5 sections, and it can be very, very easy. I like to do simulation as well. I will take all of the components that one would use, find out, are they grabbing what they need to grab? Are they using it as they should be using it? Are they using it in the right order? So I'm doing that observational study, and finding out what's the breakdown in the system. I can use huddle sheets for teaching based off of what I have found there. So there's a lot of things that you can do, and the web is full of concepts and ideas to do that. So we can look, we can say scholarly teaching exists in academia, but we can really provide the same quality at our bedside and within our institutions. If you have a medical library, if you're fortunate enough to have that and you have a librarian, have her look up articles for you. Use it, right? They love to help. Google Scholar, not Google, but Google Scholar. It's free, it's quick, it's easy. It can pull up articles for you. And you can then, of course, still do that vetting through there. But it's an easy way to get it where you don't have to pay for that service. If you have nurses in your institution that are working on their master's degree or they're doing a capstone project, get them involved, into potentially a blood culture project. It's great. And the important thing in all of this, and I don't care if you do a simple little video that helps, if you do a huddle sheet that worked, if you do a checklist that worked, if you do a full soup to nuts project, we need, as nurses, to start disseminating our work. It's all valuable. There's not a lot of current literature out there on this, and that's evident on our need to start disseminating our work better. We are a smart group of women and men, and we need to publish and become involved in forums such as AVA. One second. My clicker. Thank you. All right. So let's talk about PEDS a little bit. Cheryl went over the PEDS pieces very, very nicely. Now, one of the things that I did want to bring up is we really perceive the blood culture collection process as a low risk, and it really isn't if we think about it, especially in this population. But an unidentified bacterial sepsis has a high mortality and a morbidity. So we're kind of stuck and have this balance there that we need to think about. But I believe, as Tammy said, we have a very high false positive rate out there. So I think we need to think about that as well. The figure I had was 50% false positive. I think Tammy's was a little bit lower, but it's high. It's not acceptable. These false positives are going to contribute to patient harm or longer lengths of stay, the antibiotics that we've talked about, and the increased costs. I am repeating, but it bears repeating. And then if we look at this vulnerable population here of these little kiddos, we have to balance the consequences of inappropriate testing and the need for prolonged evaluation of suspected infections, right? So let's think about the pediatric population. I kind of put 6 things that we need to think about, right? So we're drawing smaller amounts of blood. If we're using iodine, we need to think about subclinical hypothyroidism. We need to think about the difficult venous access. They can be hard, they've got smaller veins and they're moving targets, as I like to say. So it is difficult to do that. there's very limited data that's published in this population, which makes total sense. We don't like to, test on kiddos. And it really, looking at the yield of pathogens, right, that's going to increase in direct proportion to the volume of blood cultured, which Cheryl talked about. So that being said, when we look at the clinical and laboratory standards that Cheryl used for her part of the presentation, it does state that for infants and younger children, the volume of blood drawn should be no more than 1% of the patient's total blood volume. So on the smaller kiddos, that can add up very, very quickly. Now, when I look to see if studies on blood volume, ratio of blood to broth, number and timing of cultures, and the need to use blood culture bottles within this pediatric population that we're talking about, it was very, very lacking. It's another opportunity for us to do a little bit of research, right? And make a difference. So I did want to talk about one article that I found that I thought was very, very interesting. And what they did is they ended up drawing fewer blood cultures, and they found not a big difference, right? So it was the study was completed in a 36-bed combined medical surgical ICU or a PICU, and it admitted patients from birth to 24 years of age, so quite a bit older, big range. The study by Woods developed and tested two documents. So first they looked at a fever sepsis screening checklist. So should we be drawing the test in the first place? And then a blood culture decision algorithm. So where are we going to draw, right? So we as nurses, we struggle, right? Balancing patient comfort and best practice with any procedure, right, within this population. So the algorithm actually indicated where to collect the specimen. And that would be either peripheral or CBC or both. The emphasis was placed on peripheral, of course, which supports what Cheryl was saying. But if we had certain patient populations that were immunocompromised host, they were unstable, they would talk about moving on to that CBC. They talked about recognizing the difficulty of drawing or getting that peripheral stick on kiddos sometimes. And so they put within the algorithm that after 2 unsuccessful attempts, they would begin antibiotic administration because they didn't want to delay that due to the morbidity and mortality of sepsis. And they would draw the culture from the CBC and just document it within the checklist. So it was interesting because for that study period, the mortality within this population, the hospital readmission rates were not significantly different pre and post, right? So there was not much of a change. Suspected septic shock occurrences were decreased after the intervention, and rates of mortality in those suspected of septic shock were not significantly different in the pre and post. So still looking good. They didn't see an increase in the number of episodes of suspected shock after intervention, and it showed that delaying diagnosis by decreased use of blood cultures did not create a problem, right? And then what was interesting is they found that, let's see if I can get it, that with the balancing of the metrics and keeping all things stable after the intervention, the clinicians were still ordering blood cultures appropriately. Okay, and so they were making really good decisions following this. So they had an overall reduction in blood culture utilization. They had an overall reduction in suspected infections and suspected uh, septic shock occurrences. So if they looked at those two outcomes together, by definition, they would have required the initiation of new antibiotics, but they didn't. So they felt that further investigation into looking at this may prove that by using the algorithm and drawing less, more appropriate blood cultures could have a positive impact on antimicrobial stewardship as well. So I think that that shows us that if we can collaborate with physicians, IPs, pharmacy, we are further demonstrating our value and understanding that supports the model that I was talking about. So, right, we can go from teaching as well as in our research or quality improvement with some very good outcomes. This is the article that I found. I was able to find it on a free site, but I cannot share it with you because of copyright, but you can look it up for yourself. I do believe that there really are multiple opportunities for you, the vascular access specialist, to drive value in the areas of quality, improved outcomes, patient safety, as well as really demonstrating significant cost savings through decreased contaminations. And whatever interventions you do, make sure you document it and disseminate your work, because what you do is very important and very valuable. So I appreciate you listening to me after the two great speakers before me. And I'd like to hand it over to Judy Thompson.
Thanks, Donna. And thank you to all the panelists for that really good session. Now, this ends the CE portion of the talk. And remember, you need to write down that code so you can get your CEs. And we're going to move right into a whole lot of questions we have for you ladies. Okay, first up, please explain diversion of 1 ml for PEDS culture collection. I think that might be you, Cheryl, talking about amounts.
What was the question again? Please.
It says, please explain diversion of 1 ml PEDS culture collection.
When you look at the diversion volume required for a pediatric patient or an adult patient, those diversion volumes can vary. And the diversion volume of 1% that are in the 3 guidelines are looking at mostly studies that have occurred on adult patients. There are currently some data and some studies being done right now looking at a diversion volume that's less than 1 ml in pediatric patients. It hasn't been published yet, but it should be ready to go, how long it takes to get things published. But that's the difference in the diversion volumes, but it is less than 1 ml.
Thank you. So do you know what % of blood cultures are collected by vascular access teams versus phlebotomy versus bedside nurses to the group? Okay, Donna's saying no. Tammy, Cheryl, any ideas on this?
I can look at what I'm seeing in hospitals. I know if we have 1,000 cultures, as I mentioned, a month, 500 to 600 are going to be drawn in the ED. So that leaves 400 to 500 on the floor. Not all hospitals have phlebotomy teams. I just learned today from a hospital that I'm working with, they don't have a phlebotomy team. So all of the remaining blood cultures that are drawn there, 400 to 500, are going to be drawn by the bedside nurses and the techs on the floor. When you look at vascular access nurses, I haven't really seen vascular access nurses take the handle and move forward with collecting blood cultures as part of their routine work. And I think Donna hit the nail on the head when she said, you don't have time. When you're, doing your procedures on these critically ill patients, you don't have time to collect blood cultures. But I don't have a specific breakdown.
Well,
I
and
think
I
there could
think
be a good
Cheryl
business
brings
plan
up
for that.
I'm sorry,
Sorry,
I
Donna, go
think
ahead.
Cheryl brings up a very good point in the fact that out of all the assessments I've done in all the hospitals I've been in, I have not seen a vascular access team be responsible for blood cultures. The majority of them are done in the ED, and that could be a nurse or a tech. And I think that we underestimate training with techs, which can be a problem. But I do think if you have a high contamination rate and you're paying all that money that Tammy talked about, you could make a compelling argument for an FTE or two to your VAST team.
And Judy, I've seen in a
Just
couple of university hospitals where in inpatient side, so ED is responsible for drawing their blood cultures, and they may have a phlebotomy team in the ED as well. But on the inpatient side, I've seen in these university hospitals them have an ability to call the vascular access specialist when there's a difficult stick and where it's just beyond the phlebotomist. And so again, that's a tremendous opportunity for these very highly skilled specialists to be able to help get this test right.
I think that could be a really good business case. Donna, to your point, it would, that kind of writes itself almost. All right. Can you comment on the rapid pathogen identification technologies for initial diagnosis?
Sure, I can comment on that. There's very many platforms from PCR testing, NAT nucleic acid amplification testing. It's usually done not point of care, but when the blood culture pops positive. So every time we have a blood culture that pops positive that was a contamination, it's done unnecessarily, and that's at great cost to the institution. So another reason why we want to get only what's in the patient's bloodstream into the blood culture bottle and not what was on their skin.
Thank you. Have you compared the sequestration process to just drawing a discard specimen like we do with central line cultures? Cost difference?
So
That
obviously
I
there's,
can take that one.
go ahead.
I can take that one. When I talked about manual diversion versus initial specimen diversion, that was a comparison of the two. And the problem that occurs with using a diversion tube is it needs to be sterile. Because if the top of that tube isn't sterile, it contaminates the needle itself. And then, so while it may seem to be cost effective because it would be cheaper than buying a device, for sure, but when you look at your outcomes and one contamination being around $4,000, it really isn't a good trade off.
I think another important part of that, Judy, too, is looking at it's adding steps to already complex procedure, right? And then if you look at the BMJ study, where they tell us that if you force functions, that when we engineer human variability out and we have an engineered approach, that's where we really see desirable and sustainable outcomes. And I think that's the key in this, is that we want what's best for our patients.
Absolutely. Thank you. Okay, a neonatal question coming your way. These patients have such small circulating blood volume, and preservation of volume is important. What is the recommendation for these patients that become depleted so easily?
Yeah, that's
Well,
definitely. Yeah, Donna, go ahead.
no, you go ahead.
I was going to say, especially now, let's add diversion into that, right? So that's where you need the smallest diversion volume that you can get, and there are studies with some smaller diversions coming out. And you need to be aware of how much blood is being drawn on this patient per day, per week, and then as an outpatient per month. So, certainly a great topic of interest is the neonatal patient and the blood culture.
Donna, did you have something to add?
I think Cheryl pretty much summed it up. It's the overall volume that they're drawing, but certainly less is more. But
There you go.
we really don't want to end up with false positive, in that, especially in that population. I think if we could come up with some studies, really looking at that, what that volume is, it's going to have to be prospective, but I think that could be very beneficial. It's just a very extremely difficult population, um, but hopefully technology will improve where we can divert enough, to get accurate testing.
Okay, Angela, I think that was a call out to you since you wrote the question. Maybe a study in your spare time. Spare time, oxymoronic these days. All right, Matt's saying, when drawing blood cultures, would drawing a 1 ml waste do the same thing as a diversion device?
And I think
Depends on
Cheryl
what
addressed
you're
that well.
using.
Yeah. In all the studies that are in the literature, really, we see them able to decrease rates. Haven't seen a sustained outcome with that. And the decreased rates usually go to about 2%, the best studies that I've seen in those studies with manual diversion. And I think the problem with that is when we look to, is 3% acceptable? Is 2% acceptable? Is 1% acceptable? And I think really where our mindset needs to be is that we should have 0% contaminations. That's really, zero means zero harm for our patients. And I think there's ways to always get around things if it's a little bit cheaper, but then what is the cost in the end to the patient and to the hospital? And I think we really have to look at the whole, like putting the pebble in the pond. There's a effect from a contaminated blood culture. You can think about, even just what we discussed as false positive CLABSIs. What is the cost of that to the patient in antimicrobial and antifungal therapy? And then what's the cost to the hospital to have to claim a CLABSI that really wasn't there? So all of those things must be considered when you're looking at this.
I think you also need to look individually at your process. I'm all about okay, where's the lapse? Where's the problem? Because, it is a whole procedure, right? And it's a whole process. And so taking the time to do that observation and looking for that human factors piece of it, am I setting up the nurse to be successful? Especially when we're building a kit. Where are we having lapses where contaminations can occur? Got to fix those. When we look at, maybe your institution can't afford a diversion device, but you still want to provide good practice. You've got, you're going to use a red tap tube. If you have it in a kit and the kit's been sterilized, then you're starting with a sterilized tube. So I think that each individual hospital has to assess their problems that are occurring and then come up with the solutions that fit their personal issues. Sustainability, I get it. And that is, in fact, a struggle for most process improvement projects at any hospital on any level. And that's another thing that supports building a vascular access team with that expertise, that understanding, right? And it's another value add to the team.
Thank you. Thank you. I think we have time for just one or two more. So now, to your point, I think you just started to cover this a little bit, Donna. If wasting an extra vial as a red top is recommended prior to blood culture collection, how is the waste tube not contaminating the sample? We practice cultures other than lab collection to prevent contamination. Rationale being regular tubes are not sterile on the outside.
Yeah, that's absolutely right, and I think she answered or he answered his own question. That's the problem with manual diversion. The tube must be sterile in order to keep the system sterile for the blood culture collection.
I had another really. Oh, okay. So Cheryl, RID guys want cultures to be drawn at least 30 minutes apart and prefer an hour apart, regardless of the site used each time. The reason is that if there's a false positive due to a transitive organism, it would not show up in both culture sets. Can you address this?
The recommendations previously, and I'm not sure, how these ID docs are practicing, but the recommendation initially was that all blood cultures do need to be separated by a half hour. So you would draw one in one extremity, come back a half hour later and draw it. The data since then has shown that blood cultures can be drawn at the same time as long as they're from a different site. And the whole purpose around that is is you're looking for the bacteria moving through the bloodstream in different areas of the body. Now, I suspect that practice that clinician was speaking about may be for endocarditis. And the recommendation with endocarditis is 3 to 5 blood cultures over a 24-hour period, or 3 blood cultures that are separated by 30 to 60 minutes. So if the clinician may think back on, why that physician is ordering that, perhaps that was the reason behind it.
Okay, well, thank you. Well, guys, that was the last question we could take. And this has been a great conversation and so needed at AVA. So I think this was wonderful. So, ladies, thank you so much.
You're
Okay, folks,
welcome.
we have one more session to go. We're on the home stretch, and it's worth the wait. Join me back here at 6 p.m. Eastern as we talk all about magic with Dr. Chopra, Tricia Clyden, and Stephanie Pitts. Guys, thank you so much again. You're wonderful.
Thank you.
Thank you.